My name is Renee Balliet, and I work for a company called Hayes. And many of you may not be familiar what Hayes does. We are an evidence-based company. We provide information on medical technologies that uses evidence. And my role at the company is to inform genetic testing. So myself and my group assess genetic tests, and I'll get into that and what we do. So first, why use evidence-based medicine? Well, it's because as a patient, we have some patients in there, do you want to be the first experimental patient? Or do you want a treatment or an approach that has been known to work for others? And so the use of evidence-based medicine as a patient, you should be asking for that. Physicians and policymakers have been using evidence-based approaches to guide their decisions and treatments, and this is something that's becoming increasingly important for patients. They want to see the evidence for what is being proposed. So let's start with the definition. Evidence-based medicine is the conscientious, explicit, and judicious use of current best evidence in making decisions about care of individual patients. It integrates clinical expertise with the best available external clinical evidence from systematic research. Now, this is an older definition. I think one key point that is missing here is it should also involve consultation with patients. Patients should be involved in this process. And as a patient, you should want to know what is the evidence for what is being recommended to you. So I think, I might be slightly biased, but there's a lot of value to using evidence in the treatment of patients. So the gold standard for evidence-based practice or evidence-based medicine is systematic reviews. And this is kind of follows a scientific process of you ask a specific question. Yesterday we heard about cleft palate. When you look at PubMed and you do a quick search, there's over 25,000 articles. That's a lot of information to go through. So by structuring the question and developing a protocol, you can use patients, you develop your protocol to identify the specific population, intended outcomes, and really develop a search strategy to identify all the articles and all the evidence that support your critical question. You conduct a literature search. You select the studies based on your protocol for inclusion and exclusion. And then you evaluate the studies. You extract the data and really identify if these are high-quality studies or low-quality studies, and you then present the results. This allows you to look at the evidence as a whole for your particular indication or question. And this type of approach is the foundation for comparative effectiveness research, which is comparing for medical devices, one device to another. Which one's better? Which one should I use? So this really gives structure around decision making. And this, again, is traditionally used by policymakers and clinicians, but we're seeing an increased demand, and as it should be, from patients wanting to know, wanting this type of information before a decision is made. So when it comes to genetic tests, I love genetics, but man, is it challenging. When it comes to genetics, health technology assessments are a different type of form of an evidence-based approach. And in genetics especially, there's three key areas that you want to assess. The analytical validity. Can the test accurately detect whether a specific genetic variant is present or absent? Does the test work? Clinical validity. Now this is a tricky one. Is the genetic variant being tested associated with a particular phenotype or outcome? We've heard several presentations that highlighted that clinical validity, you need large data. It's, there's pathogenic variants and benign, but there's variants of unknown significance, likely pathogenic. What do you do with that type of information? Can you make decisions on a likely pathogenic variant? What's the level of criteria needed to say, yes, this warrants further testing? So clinical validity is, right now, especially a very interesting area in genetics and challenging. We have to, especially from evidence-based, what's the cutoff? And these are all things we need to really be working at together to address. And then ultimately, clinical utility. Does the test provide information about the diagnosis, treatment, management, or prevention of a disease that will be useful for the physician or the patient? That's the key question. Is it going to change patient management? Is it going to improve patient management? With genetics, we like to introduce, because of the implications of genetics, germline testing, it can also impact patients' family members. We like to expand that approach, or that definition, and say, is it going to be beneficial for society? As we talked about newborn screening this morning, it has a societal benefit. And does it impact related individuals? Now, by broadening this definition of clinical utility, Hayes as a company, we have many payers that subscribe to us. They use our evidence-based approach. Mark and his group take a very academic approach, very leading the way approach. Many other groups that use our services may not have that same approach, or they have different guidelines. So when we assess clinical utility for evidence-based, we assess it in a broad approach, present everything that could be defined as clinical utility, and provide that information for either the payers or providers to make decisions on. Is it going to improve patient management, or is it only going to give a definitive diagnosis, even though there's nothing you can do with that treatment? So we've really tried to look through the literature and present all that type of information. And as Mark went over, clinical utility is key, but for genetic tests, it also should show analytical validity, clinical validity, and ultimately medical necessity. And as he highlighted, this can really change by the payer, contract with employees, government laws, government regulations, state and local. So these are the main criteria that are considered for genetic testing. Now I'd like to have a little fun with the current genomic testing environment. So we have the background, we have evidence base, but what's really going on with genetic testing? We talk about, we want to know analytical validity, clinical utility. Well, those terms I'm referring to are kind of the ACE model of assessing genetic testing. That was put together by EGAP, and they highlight those are key components of genetic testing, which they are. But EGAP and those initial ways of assessing genetic testing was produced around the early 2000s. And as you can see, the number of genetic testing has grown exponentially. Take the number of tests and put that into an environment where there's minimal regulation. And what do I mean by that? Well, the FDA regulates all medical devices, including in vitro diagnostics, which genetic tests would follow under. However, laboratory-developed tests are developed in a single lab for use in that specific lab. So while in vitro diagnostics are regulated by the FDA, and they go class 1 through 3, and it's based on risk to patient, laboratory tests are not, and they're only subject to discretionary enforcement by the FDA. And guess where most genetic tests fall? Under laboratory-developed tests. As of mid-September, according to genetest.org, there are over 64,000 genetic tests, over 4,000 disorders, and there's over 1,000 clinics and laboratories offering these tests. Of these 64,000, the FDA has approval for 58 nucleic acid-based tests, and 29 companion diagnostic tests. A fraction of the tests that are out there. There has been and is continuing work around regulation and recommendations for genetic tests. There's 64,000 genetic tests. How do you assess analytical validity? Is that information even available? So the FDA, if it's not used for in vitro diagnostics, it kind of falls under CLIA, which regulates laboratory. But CLIA isn't set up to really examine the analytical validity and clinical validity of genetic testing. It just certifies a laboratory. There's the College of American Pathologists. They're actually just releasing some guidelines to help structure labs and provide guidelines to make sure that when you're ordering a test, there's analytical validity through their accreditation. Also, there's the CDC and New York State that have specific recommendations. And there's societies that also provide guidelines to help us, put some kind of, I call it the Wild West of genetic testing, put some kind of regulations around it. Because right now, without regulations, if you go onto many of the manufacturers' websites, they can make any type of claim they want about the genetic test. There's usually very little information of what they're actually doing. They're doing next-generation sequencing, how many genes, if they're doing whole exome or whole genome sequencing, what's the coverage? That information isn't provided. They're making claims, and you may not be able to get that information. And again, this is completely, currently okay because there's not much regulation. We have seen cases where that FDA has stepped in, 23andMe, very popular case. But for the most part, there's so many tests, no one's really able to address all the issues that need to be addressed. And the FDA is currently have out guidelines for regulating next-generation sequencing for germline mutations. They just met last week. They have a call out for any feedback. They are working on it, but right now we're working in an environment where genetic testing really is being offered by many people, but really no regulation or clear standards. So what does that lead to? Well, with minimal regulation and oversight, you can order a test anywhere you want. These tests, depending on the laboratory, are continuously changing or updating. You may be aware of that. They may not inform you of that. They don't need to. For one indication, you can have hundreds of genetic tests. Now, I know there's many genetic counselors in the room, and I'm sure you get very frustrated when you're submitting a genetic testing form to get covered by an insurance, but there's so many different tests. How does that lab have analytical validity? How does it stack up to other laboratories? That type of information isn't readily available. Not only is it genetics, but within genetics, there's the multiple technologies used, whether it be Sanger sequencing, next-generation sequencing. Within those technologies, let's just take next-generation sequencing, you can do whole exome, whole genome. It depends how you slice it. Are you looking at SNPs? Are you looking at whole genes? There's so many things you can do with genetics that one test for one indication, you can be looking at completely different things. And that type of information is not readily available to necessarily people who are ordering it all the time. You also have designer gene panels where manufacturers now allow people to identify the genes that they're interested in screening. As we talked about earlier, and as I mentioned, whole exome and whole genome sequencing. And what's currently happening is this room is very unique. We have a lot of geneticists, all geneticists, people who really know genetics. But what's happening is a lot of the manufacturers and laboratories that are offering these tests are marketing directly to the physicians and clients. Well, what does that mean? We know that physicians, the gynecological, OB-GYN, are being marketed to. They may not have the genetics background, but they're being marketed to for these tests. Cancer oncologists are being heavily marketed to, and then the clients themselves. And again, there's no regulation over what they market. And some of these, not all, but some of the marketing, if you really spend the time and read through what they're claiming are their claims and the technologies you're using and the genes they're using, it's quite surprising. So when it comes down to payers making decisions, you're the experts, you are genetic counselors ordering it, you know it's the right test, but a lot of times it's not genetic counselors or geneticists, or people who even have basic background. A patient is requesting it for their physician to order. So if you take that type of environment, no regulations, we know there's a shortage of genetic counselors, and then couple that with non-specific CPT codes. The payers are receiving these requests for tests. They can't tell what the test is. There's a few hundred CPT codes for over 64,000 tests. What's being ordered? And you usually can't tell a lot of times. So there's been a lot of denial of coverage, even in some cases when it's legitimate, because of these non-specific CPT codes. And costs. A lot of the manufacturers will play with CPT codes. They used to stack them. That's no longer allowed, but they'll know a certain threshold for a payer, and they'll change the CPT code such that they can slide it in, get their test covered for. But there's very large inconsistencies when it comes down to costs in these genetic tests. So this is a great time in genetics, but also there's a lot of challenges. How do we get physicians and providers in sync with the manufacturers and the health insurance and the patients? Ultimately, everyone wants to help patients, but we need to get everyone in sync in order to make sure, one, they're getting the correct test, their information provided on the test is accurate, and they understand what they're getting when they're getting genetic testing. So I have a few suggestions to getting everyone in sync. First is testing transparency. As I said, since I keep referring, there's very minimal regulation. When you look at different labs, you can't always tell the methods they're using, which is a big problem. If they're saying they're looking at the BRCA1 gene, and that's all they're telling you, or are they just looking at specific SNPs? Are they sequencing the whole gene? Are they only looking at the coding regions? You need to know what's going on. And you as genetic counselors, I would like to empower you and ask that you demand from the manufacturers that they tell you what they're testing for. Because that's not always the case when we're reviewing some of the tests that come in. You have the power to make sure that they're being transparent. Costs. Again, some are forthcoming with their costs. Others are not. Coding, and I think this would be one of the biggest helps for the payer, provider, and patient. If there's better coding, you know what you're testing for, it would really go a long way in improving the approval process. And this is something I know there's different groups working on it, but I think coding is essential to getting everyone in line so we know what's being ordered. And when you're talking about testing, we have to talk about the limitations of the testing. Genetic counselors and those trained in genetics do an excellent job of explaining variants of unknown significance and incidental findings, if that's applicable to a test. But when you have those ordering the test who are not trained, getting these type of findings, what are they reporting to the patients? It's happening. And that goes to appropriate ordering of the test. As Mark pointed out, clinical utility. Make sure the test is going to do something. Explain to the payer, if you're requesting a test, what is that test going to do for that patient? That's one of the best ways to help support a test being used. Accreditation. And this one I'm leaving broad because I think there needs to be accreditation for the laboratories conducting the test. More than just, CLIA is not enough. The CAP certification is going in the right direction. New York State has some great guidelines for genetic testing, but there needs to be more accreditation so that you know there's analytical validity for the test you're requesting. Also, accreditation or certification for physicians or those ordering the test, making sure they have the basic knowledge of genetics and how to handle the reports and the information that's coming in so they can appropriately give that information to the patients. And ultimately, these genetic tests need to demonstrate analytical validity, and clinical utility. The FDA, as I mentioned, for a germline test, have been proposing how to handle the analytical validity and clinical validity challenges. Again, how do you regulate over 64,000 tests? All using next-generation sequencing, but each having a secret sauce for their own. And similarly, clinical validity, I know they're proposing maybe certifying databases that you can use to help validate. And then clinical utility, that's just peer-reviewed, we show that the genetic testing works, shows that it changes patient management. And that goes back to peer-reviewed evidence to back up the claims. And this last one I have in here, in this group, everyone knows the difference between a germline versus somatic variant and how genetic testing might be approached differently. Somatic variants are more of your tumor profiling type of test, and the criteria and standards for those are slightly different than germline tests. So just really educating and being knowledgeable about genetic testing and helping distinguish the types of genetic tests so that everyone's on the same page would be very helpful in getting everyone in sync and improving. I'd like to thank you all for your attention, and if you have any questions.